recruitment is often a challenge. Details about recruitment efforts and outcomes are rarely published, which leads to limited knowledge about why recruitment rates vary between studies and what the most successful approaches are for recruiting study participants. So does anyone have any ideas of how and when studies recruit participants? There's a lot of answers here. If you have any ideas, feel free to put them in the chat. So the first one I'll talk about is what I've most commonly seen myself when I've worked on research studies. It takes place in a traditional clinic setting in person. The study team will review an investigator or collaborating physician's clinic schedule to identify eligible participants and approach them during their standard of care visit. This method of recruitment tends to be cost-effective and can be very efficient, especially for studies with a high volume of potential participants. When conducting this style of recruitment, it is important to consider the type of visit the patient is having with their provider. If the patient is receiving news such as a surprise diagnosis, or they are hearing that they need a certain treatment, such as surgery or chemotherapy, it may not be an appropriate time to approach them about something like an observational research study. But for other studies, like treatment studies, this may be the only time patients can be enrolled. So it's important to know your study and when is an appropriate time to approach certain participants. When in doubt, it's always a good idea to ask the PI or treating provider for guidance on if a specific patient is appropriate to enroll in a trial. This style of recruitment can be difficult with more involved studies where there's a lot of information to convey in a short clinic visit. So in situations like those, it can be a good idea to follow up with the participant after they leave the clinic with another recruitment strategy. Another method that is used to recruit participants is printed materials such as flyers, letters, and pamphlets. Pamphlets, letters, and other handouts can be given at recruitment tables, health events, directly to patients in clinic, or mailed to potential participants. When utilizing these, it is important to follow your institutional guidelines and your IRB-approved recruitment plan. For example, at university hospitals, we would usually have to limit how many letters we send to patients at one time. And we would have to be pretty descriptive with where and how we were identifying the list of patients to send letters to. Flyers can be placed in clinics, waiting rooms, high traffic areas such as lobbies, and more. Generally, you should only be placing these in areas you have received permission to place them. One of the big issues with this style of recruitment is it can be easy for your population to overlook these if not utilized correctly. You can try and overcome this by considering how you can concisely explain the study without providing too much information by adding some graphics to make these materials more eye-catching, including a call to action that resonates with the reader, and by ensuring the materials are readable, accessible, and appropriate for diverse audiences. Another method of recruitment that is becoming more popular is community-based recruitment, which can be similar to in-person recruitment, but instead of identifying participants in traditional clinic settings, the recruitment efforts are often taken out to different non-clinical settings based on the intended population. This can be at community health events, churches, local nonprofits, patient advocacy groups, or other locations. Collaborating with local groups can have many benefits since these organizations have already gained the trust of their community, which can help with forming a positive connection with potential participants. This type of recruitment strategy can be extremely effective, especially with underserved populations who may not be as comfortable in a traditional clinic setting. Community partners can be an invaluable resource even before the recruitment effort begins, as these groups can help with developing recruitment plans and materials to be more appropriate for your intended population. The last method of recruitment I wanted to discuss in this presentation is digital strategies. Digital recruitment strategies include emails, social media posts, search engine advertisements, Epic My Chart messages, and more. Online advertising for a study has many perks, such as being able to reach a really wide audience, and it typically allows for targeting based on specific demographics such as age and location. Also, many of these platforms offer differing levels of reach based on your budget. Email recruitment and MyChart messaging can also be very effective in certain circumstances. Tools like Epic and Trinetics make it very easy to query for patients who meet your eligibility criteria and can be used in combination with something like RedCap to automate the email process. Like I mentioned previously, these materials will need to be IRB approved, and your recruitment plan will have to outline how, when, and where they will be used. So now that we've gone over a few methods researchers use to recruit potential participants, let's go over some do's and some don'ts for creating your recruitment materials and approaching participants with them. First and foremost, you always want to make it clear that you are recruiting for a clinical research study or a trial. This will typically be one of the first statements included on a research consent form, and most IRBs will want this to be clearly conveyed on all of your recruitment materials, whether it's a phone script, email template, online advertisement, or flyer. You will also want to make sure that you identify the PI of the project and provide their contact information, as well as providing contact information for another member of the study team, like a study nurse who is more easily reachable than the principal investigator. Next, you will want to make sure that your recruitment materials are appropriate for your intended population. This can be translating flyers and consent forms if your population is less likely to speak English fluently, or adjusting the reading level when recruiting pediatrics. And finally, you want to always be clear and upfront about the purpose of the study and the potential risks and benefits of participating in that study. If anybody has any other tips that researchers should keep in mind when recruiting potential participants, please feel free to put them in the chat. In addition to things that you should do, there's also many things that you want to avoid when recruiting for a research study. One of the biggest ones is using deceptive language or overselling the benefits of participating in a study. Deceptive language doesn't always have to be providing intentionally misleading information. It can also look like incomplete disclosure about certain aspects of the study, such as the risks or leaving out information about certain procedures. Another big one that you do not want to do is to use financial compensation as a way to coerce people to participate in the study. Many studies do provide participants with financial compensation for their time in the study, but it's very inappropriate to present this as the main reason to participate. The main deciding factors should usually be the potential benefits, risks, and the time commitment involved with participating in that study. And finally, you should avoid making claims that the study treatment is safe and effective or equivalent to or better than other treatments. Treatments are being researched for a reason, and they typically do not have strong generalizable data yet. Some studies, you will see very strong anecdotal evidence of benefits with your participants, and it can be very tempting to mention that when recruiting new participants, but it's important to be honest and clear about the study treatment not yet being proven. So now that we've discussed some methods researchers use to recruit patients and have gone over some tips to follow when recruiting patients, let's talk about developing a successful recruitment plan. In my experience, when recruitment goes wrong, it's typically because the research team overestimated the number of participants available to recruit and did not prepare for a challenge. When starting a study, the research team will usually conduct a feasibility assessment to calculate the number of patients who are available at their institution to recruit for that study. The research team will use tools like Epic Slicer Dicer or Trinetics to build a query of the study eligibility criteria and receive a number of the patients who could be recruited for that study. If the feasibility data is strong and looks like there's a large number of patients available to recruit, it can be very easy to assume recruitment will be a breeze and that a thorough recruitment plan is not needed. Feasibility data isn't always the most accurate, though, since some eligibility criteria can't be queried or the underlying data isn't accurately reflected in the electronic medical record. For example, one study I personally worked on that encountered recruitment issues was a type 2 diabetes study where the study participants were put on an insulin pump instead of their typical injectable insulin. One of the eligibility criteria for that study was the participants, if they were on a medication other than insulin, their dose had to be stable on that medication for at least 3 months. This ended up being a problem for us because we could query for if they started or stopped other medications, but it was difficult to query for dose changes since those were only mentioned in the visit note. So when we were conducting the study, we found the feasibility data looked great, and we thought that we could recruit a very large number of participants quickly, just by finding them in their clinic visits. But when we went to go do the study, we found that many of the patients that we were approaching weren't actually eligible because they were having their dose titrated at their 3-month follow-up visits in the clinic. So for that study, we were already falling behind and we had to scramble to come up with a new recruitment plan on a short time frame. If from the start we anticipated a tough time recruiting participants, we could have had email templates, phone scripts, flyers, and other methods of recruitment designed and ready to go before the study had even started. I've seen this with so many studies where the study team is struggling to enroll, and part of the reason is they are only trying one method of recruitment. Sometimes the study team doesn't know what other options are available and effective, so it's always a good idea to connect with others out there that are involved in recruitment to see if they have any ideas for strategies that you can incorporate into your study. When utilizing a flexible approach to recruitment, it is important to make sure your methods are appropriate for your population. Studies enrolling young adults may not benefit from a recruitment plan based around snail mail or phone calls. It may be easier to reach them through things like email, MyChart messages, or social media advertisements. Recruiting underserved populations using traditional recruitment methods is also very challenging. And many studies that are being done now are starting to see good success by collaborating with community partners. It's important to identify potential barriers to recruitment and incorporate strategies to remove and overcome those barriers. You should also consider taking steps to make it easier to participate in your study, if possible. Things like building a pre-screening tool in REDCap for participants to fill out before being in contact with a member of the study team can make it easier and can make it seem like less of an investment for the participant to think about participating in the study. And you can also incorporate different decentralized aspects into your study to ease participant burden. It can be uncomfortable and inconvenient for participants to frequently drive to the study location for their study visits. And by adding the option of things to your study like remote electronic consent, virtual visits, remote data collection, and flexible lab collection, you can make your study more available to a much wider audience. Another method of decentralizing that is available to study teams in the CTSC network is the UH Mobile Research Unit. The unit features 2 exam rooms, a fully functional lab processing center, and it can be requested to take your study outside of the traditional clinic setting. The CTSC has multiple funding opportunities available that are eligible to use on the mobile unit and also other CTSC services. These include the voucher program and the core utilization program. If anyone is interested in learning more about decentralized clinical trials, the January episode of the CTSC Distinguished Speaker Series is being hosted by Paul Harris from Vanderbilt University on the topic. Paul is the Vice President of Research Informatics at Vanderbilt, and he is one of the individuals who helped create REDCap. So this should be an exciting episode for anyone who's a big REDCap nerd like me or just wants to learn more about decentralized clinical trials. So I know that was kind of short and very quick. If anybody has any questions, please feel free to let me know. And also, if you have any issues with your developing recruitment plans or having issues with your recruitment methods and your studies, uh, please feel free to visit spark.case.edu and submit a request for clinical research recruitment and support.
Oh, I see Dr. McCumsey has her hand raised.
Yeah.
Thank you, Jerry. So I just want to remind you, the audience first, right? Science Cafe is supposed to be more like about discussion. So you gave great, feedback with slides about what recruitment is, different methods, but I think we want to make sure like people, open up talking about their experience, maybe talking about anything that maybe you have missed. Since we have seen the list, we have people from our different partners within the CTSC. So I just want to encourage people, and I want to remind them of something that's really bad. Why do we talk about recruitment? FDA actually did a study a couple of years back and published that 80% of clinical trials do not reach the intended target size. So imagine 80% are having a hard time recruiting participants. And I know even from UH, when I, in 2017, took over the Clinical Resource Center, 25% of studies had not enrolled a single patient. So it is extremely common to have recruitment concerns with the study. And this is why we have Jerry, who has a lot of experience recruiting for clinical trials. So anybody from any site within the CTSC, if you're having a hard time recruiting, Jerry would be your first contact to try to, he can study the situation and see, does social media help you? Should we, have you connected with different community organizations that we do health screening, health events with? So I just want to prep by saying, this is why we want to discuss this. It's a very important topic. It's a problematic thing in clinical research, and we want to help you within the CTSC. And Jerry's help is free of charge. So that's the other good thing. And I before I open it up, I put one thing, always when you call patients, I know at UH and probably other partners as well, we don't allow cold calls, right? So when you call in somebody and to say, it's good to say, I'm calling you to be recruited, talk to you about a clinical trial, the PI and so. Imagine you're the patient, you don't know who that physician is. So it helps sometimes to say, who referred you? How did you get the patient name? So Jerry just finished working on a tablet form for recruitment of participants, where at different events, people can tell us if they are interested in being contacted for research. So if we have, for example, on the list here, a researcher interested in diabetes, we may have for you, a list of people with diabetes who said, if you have a study on diabetes, contact us. So when you call these people, you would say, I got your number from the database that you signed up for with the CTSC. So the point is, it does help to say, why are you calling these people? Having cold calls, not knowing that, and say, oh, this is UH calling you, that never actually ends up well, really. So it's important to say why you're calling them, who referred you? Was it their physician? Was it them saying, I'm interested? That helps tremendously in people being interested. So I'm going to stop there. I know there are a lot of people who are very experienced in recruitment and enrolling in studies. So I'm going to open it up for people to just discuss. So thank you, Jerry, again.
Thank you. Yeah, if anybody has any studies they want to talk about that have experienced recruitment issues, any insight, please feel free to chime in.
Yes, you have a question, Jerry. I don't know if you can see it. Somebody's asking, our J1 visa staff, people who are non-volunteer, so they're employees, but they have a J1 visa. Are they allowed to recruit people? I think that's what they meant. And if I'm wrong, actually, they can correct me. I think that's just the type.
If they are listed on the study and they are delegated to perform consent, then they should be allowed. I don't think the J1 visa would have any impact on whether they can consent or not.
Correct. So if they're not volunteers, I know that there are some people on the call I know have J1 visa beside the person who just answered. So yes, the J1 visa itself is not a problem. We have a lot of postdocs at Case, for example, who have a J1 visa. It's a legal status, you know, for training and for different purposes in the US. So no problem. And Jerry's right. As long as you're on the IRB, on the personnel table, that's what counts.
Does anyone have any specific examples of eligibility criteria that are difficult to query in the EMR? Like I mentioned previously, sometimes medication doses will be in there. Sometimes if they change it slightly, that's not going to be reflected in their medication table. Things like tumor measurements, radiology findings, those are often very difficult to query in the EMR.
Well, if I could add, Jerry, one other thing, right? There are diseases where there are no biomarkers. So you're relying on physicians to making the diagnosis clinically and put in the code in EMR. But there's no way to kind of know for sure that that code is correct. So sometimes EHR is good for triaging, right? Trying to find patients. It doesn't tell you 100% that what's in there is correct. COVID is another example of trouble, right? Having done a lot of real world data with COVID. Even now, if you look in large databases, they tell you, you know, like 30% of people had COVID. There's no way. We all know that's not true, right? People diagnose at home. It never gets to the EHR. So you use them as COVID negative, but they're not really negative. So EHR is great as a way to triage, but it's not perfect at all.
Yeah, definitely. It's always important to confirm the criteria with the participant when you enroll them.
I see that Shannon has her hand up now too.
Hi, I'm curious to know, for those on the call that do recruit subjects, what challenges do you face in your work and recruiting efforts? And if we don't have a lot of folks who do recruit, perhaps if you are a study participant yourself, what types of things do you notice in studies that recruit you that you might want to share with this group? And if not, or if Jerry has any frequently asked questions that he gets from folks, if he could share that with us.
Yeah, a lot of the time, a lot of the questions I will get is simply like what's possible, what's available, what's out there. And a lot of that is very dependent on what they already know and what they're aware of and what they haven't been exposed to yet.
Oh, go
Yeah,
ahead.
so if I could comment, I don't know, I can't see when people raise their hand somehow.
Oh,
but,
yes. Nora has her hand up.
Oh, Nora, go ahead. Dr. Singer.
Oh, yes, you're muted.
So I think there are actually 2 or 3 things that we're doing in the CTSC that hopefully will help. One is something called a non-engagement IRB, which Metro has, and we're trying to, well, there'll be discussions among the IRB administrators at the other sites. And what this essentially does is basically says if you're not engaged in the research and you're just giving out a flyer, you're allowed to do that. And so I think that that may be very helpful. I think institutions can be paternalistic about owning patients, especially some of the bigger institutions in town. And that to the extent that the CTSC can be a place that things could be advertised for, that may help to overcome institutional barriers, because patients are less loyal than institutions would like them to be, and they may want opportunities around the city. So if Grace had a trial that I didn't have, I may have a patient that wants to go participate in a post-COVID trial that we're just not offering, for example. And so I would think those things in mind. So if you're putting in an IRB, or you have a colleague who's doing an interesting study and you're just not doing it, I would ask your IRBs about the possibility for a non-engagement approval.
Yeah, the non-engagement IRB at Metro is definitely very exciting. And we're kind of looking into and feeling out the waters for expanding that to other partner sites as well. Because I think that would be really helpful for a lot of people performing research in our network.
Yeah, I was gonna comment actually to reply to Shannon. So the easiest studies to recruit, Shannon, if you think about it, are people who have no good options clinically. So recruitment for cancer is always, for example, much easier if people qualify than recruiting for, like a typical infection where you have a good treatment option and people don't see it as needed. Long COVID, for example, we're living it. People are desperate. They want something because there's no treatment available. So these are the studies, if you offer, like good trials, people will come because they need them. Another thing is how much you pay them. So NIH trialed actually in some of the recovered clinical trials, paying people too much money. And I do mean very high amount of money, because the idea was these are long COVID patients. So when they come to a study, they need help. They need their kids being watched. They need potentially somebody to help them come. They need like an extra person to take time away from their work to come. So they, gave a lot of money. I think for the most part, it did help the study. Although some people were even trying to fake their symptoms, exaggerate their symptoms just to get in, because they said it to us, oh, I need that money. So things like compensation is really tricky. It does help, mainly in diseases where people need, a lot to be able to make their appointments. But sometimes it backfires. So that's why we have the IRB also sometimes resisting those large amount of monies and saying this is coercion, or this is really not helpful for the study. So that's one aspect that's tricky. Even NIH doesn't know how to deal with it, because you can see both sides for different diseases. And I think, Jerry, you have some comment from Amanda. I don't know if you can see the chat. A very good comment, actually.
It is a
So
helpful
since
practice.
IRB needs to see all the recruitment strategies, right? Amanda's right. Sometimes the best thing is put a lot to start, because you don't need them to keep amending the study to say, oh, and we need social media, and we need this recruitment. So The IRB is always, they need to see what you're gonna do before you do it. You need IRB approval for recruitment. So do it ahead. I agree with Amanda, it will save you time later.
Yeah, definitely. I really need to see all of the patient-facing material and also a pretty detailed plan of how you're going to use that material. Maura McCall, you gave us a link to participate in the registry and be a patient. Is there a link to request to utilize the registry for your recruitment? No, there is currently not. I would say if you're interested in utilizing the registry to submit a Spark request for research recruitment support.
And Nora, I know you commented on, different institutions sometimes not liking to lose a patient that they see clinically to some other site for a study. I mean, I think that's real everywhere. It's not just Cleveland, it's everywhere. But what the CTSC, and that's next on Jerry's plate, is we're gonna have a centralized within the CTSC database of all the clinical trials that are happening within our 7 partner institutions. So that patients may be able to go to that link and figure out if, let's say, they are interested in diabetes, for example, they can put search term and figure out which studies are available at the different institutions. Now, of course, UH may say, and I'm just making up, not picking out UH, but say, I don't want to put my studies there. It's fine. But we are going to have a database to advertise all the studies, because I think if you're a resident of Cleveland, we owe you knowing what studies are available.
Correct.
So
I think, sorry, did you finish?
Yeah, go ahead.
I think the other thing is that other investigators have suggested that, even if a patient goes for a clinical trial, in general, they don't switch their entire care to that institution. And so in the long run, it may not really be costing that other institution quite as much as they think they are. And patients much more, I think, than in the past, divide their clinical care between institutions rather than have loyalty to just one institution. And I think that's been probably a trend over the past decade. It would be interesting, Jerry, to be able to ask patients who have participated in clinical trials, did any of your other clinical care switch if it wasn't your home base? So that would be important data.
So could I ask Heather? I know Heather is joining us, even though she's on maternity leave. So thank you, Heather. Double thank you. Do you want to talk about the mobile unit that UH owns that's now a core resource within the CTSC?
Sure. Can you hear me?
Yeah.
Okay. Yeah, the mobile research unit is available to anyone in the CTSC and in our community and surrounding region. You can submit a request on our RedCap link. Jerry, if you have time, could you put that in the chat, please? The mobile unit can pretty much go anywhere you want it to go. We can go to your facilities, clinical sites. So UH, if we have satellite sites, we can take it there. Cleveland Clinic can utilize it, Metro Health. We can also take it to non-clinical sites, such as like a mall or a local 5K at the zoo. We have a pretty rigorous process of evaluating feasibility for parking and driving, just to make sure we're adhering to parking laws, making sure we're staying out of the fire lanes, making sure it's safe and feasible to take it for our patients. There's a certain way to park the unit to make it safe, and we also have a wheelchair lift. So when you're submitting a request, just provide details for, your patient population and what you need as far as resources on the unit, what's involved in your study visit if you want to conduct clinical procedures on the unit. And we can assess and provide not only the unit, but also clinical resources such as research nurses, recruitment specialists, coordinators, and lab processing. We have a fully equipped lab on the unit. I think that's probably one of the best use cases. We can go collect labs pretty much anywhere, process and spin them down, freeze them. And that's helpful for studies where maybe you're collecting PBMCs that have to be processed within the hour of collection. So as you know, if you're trying to, go to a satellite site, collect PBMCs and try to courier it back to your main campus lab, more than an hour is going to lapse. So that's not practical because it'll break down the cells and the data won't be good for those labs. So the mobile unit can not only save time and make sure you're retaining the quality for the sample collection, but we can also collect more samples than what you probably could do at your main campus laboratory. So last year, before I went on leave, we actually took it to East Palestine and collected, I can't remember how many, but probably between 50 and 80 samples on patients in the community that were affected by the train derailment. And that's something that probably is not feasible at one of our clinical sites just because of logistics and space. So, not only is it good for the lab collection and engaging the community, we can also reach more patients more quickly and expand our demographics as well. So if you have a study that needs to enroll, whether it's inner city or Amish community, we can take it anywhere.
And Heather, the mobile unit now is a CTSC core kind of lab equivalent, right? People can get us to pay for them when they submit a proposal.
Oh, nice.
So if anybody on or you work for a PI who has a study and they think they may benefit from a mobile unit, they have to submit to us the study and the request. And then we can help with fund. Thank you, Jerry. So up to 10,000 for the mobile unit cost, because as you can imagine, I think it was Heather and I actually that put together a budget for to try to give us more than $500,000 to fund the mobile unit at the start. So it does cost money, the gas, the driver, all of that. So that has to be paid for NIH studies. There's reduced cost versus industry, but it's still costly for So CTSC wants to help you if you have a study, regardless if you're or Metro or CCF or any of our partners, you can submit a request and we'll help you with the cost of the unit. Any other questions or comments?
I have a question. This is Cassandra. For the mobile unit, does it have to be a high enrolling study in order to use the mobile unit? Because I'm trying to see, if it was just, like a study that had 2 people coming in one day, I don't think that would be worth it. Or how does it work?
Yeah, so we can enroll as many or as little patients as possible. So basically, what we're trying to do for lower enrolling studies, maybe some of the rare diseases, we're trying to share the mobile unit with other people that maybe need it on the same day in a similar location or same location. Yeah, we have an example from last year when we had to take it far east, maybe like Ashtabula, and it was an industry-funded study. So we have it in the contract where the sponsor is going to pay for the cost of the mobile unit. And I think the study only enrolled 1 patient that day, which was fine. I mean, as long as it's in your budget, we can make it work. So if you're only enrolling 1 or 2 patients, we don't want to limit the mobile unit because obviously every patient is valuable.
It is a good question. As Heather knows, we have been successful, including in my own studies, to put it in the budget. So the put the cost of the mobile unit in the budget, and industry would pay for that, you know, happily, because as I said at the start, 80% of studies has trouble enrolling. So if you make the point why it would help. So in the long COVID study that we're doing, to go to Elyria, to go to areas with high Hispanic enrollment, for example, we deployed the mobile unit and went there, and we were successfully able to enroll more Hispanics. So sometimes it helps in diversifying the participation or the participants in study as well. There are a lot of positive, you know, reasons to deploy the unit. As long as it's justified, CTSC can pay for that or help you pay for that. Up to 10,000, you can submit a core pilot for us. I'm gonna pick on two people I know well, Dan and Brooke. I know both of you have a lot of experience recruiting. Brooke in a very novel way. I don't know if you want to comment on maybe something. I know you deal with, you know, HIV population, and you've helped us recruit in studies at very places that people don't think about for recruitment. Do you want to comment?
Sure, I'll take a second. When I started about 15 years ago, we were doing a lot of HIV prevention studies. So I needed to be out in the community looking for a whole lot of HIV negative folks. And so we tried just, you know, everything you could imagine, any kind of venue, any kind of special event, community gathering, community center, health center, festival, party, whatever, bars, restaurants, coffee shops, everything you could think of, because we needed a broad range of people who didn't have specific health concerns. So that was, in a way, easier because we could go to a lot of different places to do that. Now we don't have prevention studies currently, so I'm focused on our treatment studies. So now I'm focused in the clinic all day long, every day, with every doctor, every patient, on a particular study. But I'm also helping other researchers with their studies. You know, I'm trying to help promote the gut health study and the dental health study. So not, you know, technically part of their teams, but trying to help each other get people interested in volunteering for research.
And I think Brooke, I mean, not to pick on you, obviously, but I think it's a great example of how different studies, right, in different time of your career, different studies require very different ways to enroll people, like you said. And that's exactly what happened with any disease, you know, whether HIV or not. I mean, that's an example because you and I have worked for a long time on HIV, whether prevention or treatment, but it is important. Now, a job, we always envied you because a job to go to bars and restaurants and enroll, I mean, that's like a dream job. So we were all stuck in the clinic and you're going to all these places, but
it was pretty sweet. It was pretty sweet.
Yeah. Go where people are. I mean, that's the point.
Absolutely.
Do you have any comment?
Yeah, I joined late because I was on, excuse me, on another call. So one of our situations, we've been doing a lot of STI studies. One was or several were for new antibiotics for gonorrhea, and and then one was for a device for women where they could test at home to see if they had any STIs. So we collaborated with the Cleveland Department of Health and did the studies at those centers at Jay Glenn and McCafferty. And the most recent one we did at Jay Glenn was for the device that women could use to test for STIs, and it was very successful just because we were at the site as women were coming in to actually get tested. So I think we had like 250 and women enrolled in that study. So I think, I don't know what you talked about previously. I just got on the call here, but you have to go to the site or the places where the people are at. And that seems to work better than trying to have them come to you.
That's exactly correct. Yes. I mean, I think that's why we were talking about the mobile unit as well. Just go where people are and don't do like we did. I went with some members of the team to the Hispanic Center, and, we had a great visit. We were doing screenings, but we don't speak Spanish, and we didn't take anybody who speaks Spanish. So you can imagine that was a little tricky. But it really kind of dawned on me, like we didn't even think about it. Everybody spoke only Spanish there, and here, or only Hispanic, and then or Spanish, and then all of them were Hispanic. So yeah, we went there, but it was good. I mean, somebody from there helped us, was happy to help, and we connected with several people. But yeah, you have to be ready. You have to go to them. And you have to understand your audience and be ready, like with Hispanic translation, not go with only English and they're like, they have no idea what you're talking about. And one of our postdocs who I see on the call was trying to use the Google app just to translate so he can understand them. And they were very nice, actually. I mean, they were very patient, and probably looking at him, it's like, yeah, we looked like rookies there, but it was a good experience. We'll do better next time. Any other comment or anything that we didn't discuss in this topic? I know Jerry talked about community enrollment, and CTSC is committed to doing more of those. It is clear that just going to the clinics to enroll work for some studies, like in our HIV clinics, but not for most of the studies. Now it is about community enrollment. That's very important.
And one other thing too, I thought about, I don't know if it was mentioned before, about having people that look like the people you're trying to reach, not just going in their communities physically, but having people that's reflective. I know I did a study in with a lot of the Amish people, and one of the PIs was Amish, and we had one person say no out of, I think it was like 85 people. And it was all because I think it was a lot with that relationship with the whole practice. They all knew the customs, they knew, what to do, different things like that. And it was successful, but we did have one of the physicians was Amish, and they trusted her, therefore they trusted us. But I think even, for coordinators, if you can have people that's reflective of the community, that makes a huge difference.
Yes, that's absolutely correct. I think there are studies showing that, yes, you have to, you can't go, but that's why I talked about our Hispanic, honestly, because not only none of us spoke Spanish, I mean, none of us was Hispanic. We looked, we looked like we were these people, just trying to like butt in an area that we shouldn't be there. Now, the intent was great. We were going actually not to recruit for specific studies, but to talk about how important it is to enroll Hispanic in research in general. We did have flyers that were Hispanic, but you're right. When you look like them, you instill like certain trust, and that has been shown in several studies to help with enrollment. Amish population is a great example of mistrust in medicine overall, not just research. We tried for long COVID study to enroll in Amish population. We even enrolled the white physician who is in the Amish area, but she couldn't even help us with enrolling Amish people in that area. So we ended up taking the mobile unit, enrolling white people in that area who were not Amish. So we were not able to enroll Amish people. But I'm sure if we had somebody who is Amish, it would have helped.
I think also if it's sometimes it's not possible, but if the researcher actually has the disease in question, I know I'm HIV positive and we're doing a large repository study right now, an NIH study, and just by my fact of being open about my own status, it's helped recruit patients much easier and build trust much easier as well. So I think that kind of connection can also be very beneficial to get the study moving and to enroll high numbers.
Yes, good point, actually, Dan. Because people feel, again, it's like, looking like them, but they feel like a connection, right? They trust you. They know that you're dealing with similar issues.
And
Your
there's
comment?
also another question in the chat.
Do you find retention challenging after using the mobile unit to recruit in further away areas? Do they come to the clinic after the initial connection?
Brooke, can I tell you our experience with long COVID? So NIH was so into rural communities, right? So we took the unit to very rural communities, which was great for our enrollment, but it really hurt our retention. We tried to find, but what we did actually, we didn't give up on them. We tried to find sites, UH sites next to them that have CT and MRI and all the evaluations required to try to keep them on study. But it is a challenge because it's easy to go and enroll, at the start, but people don't want to come to main campus and it becomes harder for them. So you commit to go in for all the evaluations next to them. So you don't just hook them and then say, oh, guess what? Now you're on the study. You have to go to main UH campus for everything else. That doesn't work. They're gonna drop out. Big issue.
Yeah.
So Jerry, any last comment?
I do not have any wrapping up comments. Does anybody have any questions or any other things to add before we finish up here?
All right, so if I can, before I leave Jerry to close it, but this is exactly what Science Cafe should be like. I mean, it's discussion. We really don't want 1 hour of slides. We just have a speaker introduce the topic like Jerry did, and then have a discussion. So thank you for all the discussion and questions and answers. That's what makes Science Cafe. So join us in the future, and Jerry, let you close it.
Yeah, I just also wanted to read Heather had put in the chat. A lot of patients love the mobile unit and ask to have follow-up visits on the unit. So retention is possible if you can keep their visits convenient and close to home. And then, yeah, if there's no other questions or her final comments, I will just let you know about next month's Science Cafe, which is the QR code for this to the left. So Margie Sanders will come and talk about gerontology and a lot of her work with special populations. So be sure to sign up for that on February 13th. The middle QR code is to provide feedback about this session. And there's also a space there if you have any suggestions for future Science Cafe topics, be sure to let us know. And then the last QR code on the right is if you're not a current member of the CTSC, you can sign up here and stay up to date with all of our upcoming events. So thank you everyone for joining us. And if no one has any final comments, enjoy the rest of your day.